Well, Albert, thank you very much for that kind introduction, and also to Stanford for warmly inviting me here today. So the topic for discussion is upping the ante. We're talking about opioid injury prevention. So I'm talking to you, this is really more of a grassroots kind of boots on the ground type of discussion. What are we willing to really put on the table from a personal and a professional standpoint? And I'm hoping today to leave you with something important that you walk away with, and maybe something on your to-do list. I have no disclosures for this discussion. The learning objectives are, as you see here, to be aware and understand the current crisis of overdose deaths in the United States and the disparities there that are encountered, to think about what is your role in addressing this on a personal and professional level, and then perhaps to integrate some mechanism to be able to respond to a public drug overdose with naloxone and basic life support. So we just went through all of the holidays, and I want you to envision yourself in your family's setting, whatever that might be. I'm thinking about maybe Christmas, Hanukkah, or Thanksgiving. And I don't know about you, but I love that environment. There's a lot of people in the house. There's small children running around. And whether I'm cooking the meal or somebody else is cooking, I love the smell. Can't wait. I'm starving. Can't wait to sit down and eat dinner. And then when you do, envision yourself sitting down at the table and there's an empty seat. And you recognize that your nephew, it's called Nathan, is missing from the table. And during the quiet of the meal, you hear a thud in the house. Your sister takes off running for Nathan, and then, of course, the family members also scatter, and they're looking for him. So, of course, everybody's going from bedroom to bathroom looking for the nephew. And this is him. He's found down on the bathroom floor, and there's drugs next to him. And whether Nathan brought this in himself or whether he found this in someone's handbag or their luggage, that was either liquefied, crushed and liquefied and then injected. And by the way, these are images. This is a real picture of somebody overdosing and somebody taking their last breath. You'd be amazed at what you can find on the internet. In fact, it's a little disturbing. So your nephew is down. Someone's called 911. But now everybody's looking at you. Either you're an anesthesia resident, you're a CRNA, or you're an anesthesiologist. So the expectation is, what are you going to do? And it's clear that you have the skill set. You can rescue breathe, and I'm sure you would be willing to do old school mouth to mouth. This is your nephew. But how long are you going to have to do this until EMS arrives with naloxone or Narcan? I think we'd probably all consider it to be best practice to have naloxone in the home. Again, going back to the drugs in the house, you think that you have control of what goes on in your household and what comes in and what comes out. But in actuality, you do not. Now, that situation that I described to you, I had been in that situation a number of times. Albert hadn't mentioned, and maybe some people in the audience don't know, that I have lost both of my adult sons to accidental opioid overdoses. So I did have to give naloxone. I did have to rescue breathe, and I did full-on CPR more than once. And I thought to myself, well, that's a terrifying situation to be in. It will absolutely level you if you are in that situation. But I thought of what would it be like if I were a layperson and I had really no idea of what to do. So that's why I speak up. I write op-eds. Every opportunity that I'm invited to speak, I'm here. I show up. Okay. Now, this piece here, this is from the USA Today, and this is me on Mother's Day thinking about my memories of my mothering lived experience with my sons. And I started off talking about the negative things, like the fact that I had to remove a bathroom door with the help of my 90-year-old father-in-law who lives with me. We had to remove the bathroom door because my son's body was blocking us from reviving him. I have run down the street barefoot in my bathrobe because I knew my son had just texted someone and he was running around the corner to score drugs from a drive-by. It's easy. You can text somebody and they will show up at your house and they will drop it off. So I did finish, though, this piece with the loving memories that I have of being with my sons. They were a delight, really, and I miss them every day. This is a piece from the Philadelphia Inquirer, and it's me talking about the need to have a naloxone product in the home, and also please have some basic life support skills, particularly if you live in a high risk home where you know somebody has a substance use disorder. The flyer on the right hand side, this was actually a poster. I was able to convince the state of Pennsylvania to allow the my home institution, Penn, to participate in the free Narcan distribution day. So we distributed and trained over 850 individuals, including the entire Department of Anesthesia, all the support staff. I had people, the parking garage attendant, the cafeteria workers, they all showed up. It was very well received. This is also a piece for the Philadelphia Inquirer. I wrote an op-ed about the need to have safe house in the city of Philadelphia. I testified before city council and it was very contentious. There were a lot of angry people from Kensington. Kensington is an area of Philadelphia where it is an open air drug market. People are injecting on the streets. But that neighborhood, people that live there, they did not want a safe injection site in their neighborhood. For those of you that don't know, a safe injection site, there are over 130 such sites worldwide. There are no recorded deaths in any of those locations, so they do work. I have to say, I would actually prefer them not to be called safe injection or safe consumption sites, but because it seems to allude to permission to use, when in actuality, it's really a injury prevention site. The first thing that these people would be asked if they showed up to Safe House Philly would be, are you finally ready to embrace recovery? Do you want to get into a treatment program? And if the answer was no, they would be offered HIV, hepatitis testing services, and wound care. If they still were refusing that type of care, but they were insistent on using, then the plan was, we are here, we are ready to rescue you if you are intent on using and if you should overdose. Another piece that I wrote for USA Today, if your teenager was addicted to opioids, would you know? It's harder than you think. So when my kids were growing up, we were told that their friends would change, their appearance would change, their grades would slide. That was kind of the current thinking that we were being taught with DARE program, with just say no to drugs. Well, I can tell you that that never happened with my children, ever. What we did see were very subtle things like I would find bills missing from my wallet. I just went to the bank. I know I took 120 out, but there'd be $40 missing. And I thought stopped at the grocery store. They're very smart. You don't take all of it, you take part of it. So missing money, falling asleep, standing up. And it is very characteristic when somebody is dipping out, how they very, 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 very slowly fall forward. They take a big deep breath and then they're awake and then they continue to fall asleep. Other things like on their cell phone, they'd be missing. You couldn't contact them for hours on end. But these were the things that we were seeing. And once use went from weed and pills, well, then it went on to hardcore drugs. Heroin is sold in these little, as you see in the picture on the right, they're sold in bundles of 10. So you can buy 10 bags of heroin bundled together with these little elastic bands, and you can buy that for about $60. Whereas OxyContin was 20, 40, 60, $80 based on the milligram amount of the tablet that you're purchasing. So it was much cheaper to use heroin. Of course, now that drug supply is contaminated with fentanyl. So we would find maybe a very colorful elastic band, a very tiny Ziploc bag, that wax paper blue bag that you see there that contained the heroin. Well, you wouldn't see them all in one location, but you might find one day in a backpack. You might find that little Ziploc bag in a trash can. But over time, you'd see it more and more often, and it would add up. And you'd never find a syringe. So it was really kind of hard to pick up on. And you might say, well, gee, Dr. Milas, that's nice. You find those nice stock pictures there. These are pictures that I took of things that I confiscated in my home. Now, those are things that I've done on a personal level, things that I have engaged in. But institutionally, we're trying to also change the way, well, we're trying to really combat stigma. So the poster on the left-hand side, this was a Narcan Story Slam event where we invited people to stand up and talk about how they had revived somebody with Narcan or Naloxone. So a number of individuals stood up and talked, and I stood up and talked about how after having revived one of my sons, I had called 911. So I had the paramedics in my house, I had police in my house, and quite honestly, I was very angry with my son because I had just picked him up from a rehab treatment facility. And this was the second time in 2 days that he had overdosed. So I was really just enraged. I felt like I was putting in more time into his recovery than he was. I was more engaged. Anyway, I had to deal with the paramedic scolding me about keeping my voice down because she was trying to do her work. I had the police in the house going through my household. They're looking around. They're like, haven't we been here before? And kind of laughing. So that is truly not helpful when you're in a crisis situation. Other things that we've done from an institutional standpoint, the poster on the right, person first language. This is getting our community at Penn to try to change how we talk about people who use drugs. So rather than saying, oh, the junkie, the drug addict in bed 562, instead, no, this is Mrs. Smith suffers from substance use disorder. Give them the dignity of their name. So again, these are things that we're doing to try to decrease stigma, to get people to accept this is a disease that needs treatment. So where do we stand in the United States, our current state of overdose deaths? This information comes from the National Center for Health Statistics. This is looking at overdose deaths. These were reported from May 20 to May 2021. This is a great website. You can just scroll over and look at individual states. I pulled out information from California. So during that time period, you had a nearly 41% increase in overdose deaths. Of course, this is during the height of the pandemic. In Pennsylvania, we had about an 11% increase. So overall, across the nation, about a 21% increase in overdose deaths. This is later on in the pandemic, August 2021 through August 2022. These are predicted overdose deaths. And you can see that the rate of rise in overdose deaths is slowing, but it's still almost 3% higher than the previous year. So in California, again, the overdose death rate is slowing. Same is true in the state of Pennsylvania. Some of these states here, and of course, I didn't explain, the darker orange color to red color is where the overdose death rates are the highest. The blue states are oftentimes the information is underreported, or we just don't have all the data in as of yet. So this is essentially, this has been splashed all over the news that I think you'd have to be living under a rock not to know that overdose deaths are at an all-time high, the highest that we've ever been. Over 108,000 individuals died of drug overdose. The majority of these, about 75%, are due to fentanyl analogs or the synthetic illicit opioids. There were a number of factors that contributed to the rise during the period of COVID. Social isolation, people were stuck at home with their families all day. Financial hardships, many people were out of work. Increased synthetic opioid production. People weren't able to go to the doctors before we got telehealth systems up and running. Of course, there's always social determinants or disparities that are always at hand. So if you look at that increase in overdose deaths, I mean, if you put the 2 years together, in general, 25 to 30% increase in overdose deaths. But the disparity was that non-Hispanic Blacks, their death rate was due to overdose was increased by 44%. That was also true for American Indians and Native Alaskan persons, about 40% increase. And if you looked at regionally in those states, the areas that had the highest income disparity is where overdose deaths were particularly high in the African American population. Now, this comes from your California overdose surveillance dashboard. Again, this is a great tool if you want to see what's happening in your state. Now, in California, I said that there were about 10,000 overdose deaths in 2021. We're looking specifically at those related to opioids, so about 7,200. And if you look at the racial breakdown, 54% of those overdose deaths were white, but whites represent 35% of California's population. The two groups that were specifically hardest hit were, again, the African American Black population and the Alaskan and Native Indian population as well. And you can see that effect on the graph on the right-hand side. So higher increase in overdose deaths. Again, from your state dashboard, on the left-hand side, you can see the average crude rate of opioid-related deaths in red in the state of California. The red arrow indicates where San Francisco, in terms of counties, falls in overdose deaths. Here in this local area, which is Santa Clara, is the gray area, or excuse me, the gray arrow at the bottom. So you're on the lower end of the spectrum, but you don't have to go very far in this local area to be in a location where overdose deaths are considerably higher. When we're talking about age at which overdose death is most likely to occur or has a higher rate of overdose deaths would be in the 30 to 35-year-old age range, and the 25 to 29-year-olds are not that far behind. And that would have been where my children had fit in that same age group. I'd like to point out, though, that overdose deaths, you can see they start to rise at age 15. Now, how are we doing with overdose prescribing? In the state of California, from your dashboard, you're doing a great job in terms of putting less prescriptions out there in the hands of individuals. You're at the lowest rate, even lower than 2009. But despite the fact that we're putting prescriptions into people's hands at a lower rate, the overdose death rate continues to rise. And we know that's because, again, because of illicit fentanyl analogs. Um, Although an important point should be taken that the entry point for most people in opioid addiction is from pills. So it is important that we're doing a good job on the entry point. Now, this is for Rita Agarwal. We were at dinner last night, and she did mention this morbidity mortality report. This is information that comes from the CDC. So this is for persons aged 10 through 19. So the overdose deaths have increased in that age group over 100%. 84% of these are due to illicit manufactured opioid. 25% of these are due to counterfeit pills. I'm sure you've heard about this on the news. But this is probably, and I put it in bright purple, the thing that's most disturbing to me is that 2/3 had one or more bystanders, but no one intervened. There was no intervention. This is something that we must do better with. This is a paper that, interesting finding, was in Circulation, and those individuals, and this was done in the state of California. This is between the years of 2011 and 2014, that they looked at all individuals that were characterized as sudden cardiac arrest, anywhere from age 18 to 90. And they were originally, again, stated as cardiac arrest. However, when they looked at autopsy data and toxicology reports, is that 13.5% were due to occult drug overdose. So it's quite possible that we are actually underrepresenting those individuals who are dying due to drug overdose. Also in Circulation, this is looking at out-of-hospital cardiac arrest by age. And kind of the tipping point is around the age of 60. So if you suffer a cardiac arrest and you're under the age of 60, it is more likely to have been from a drug overdose than from a primary cardiac event. Of course, over the age of 60, more likely to be due to a cardiac event. This is information from the Transplant Registry. And over the past 25 years, the single largest increase in mechanism of injury leading to organ transplantation has been from drug overdose. It used to be that drug overdose as a mechanism of injury was less than 1%. But nowadays, we are transplanting at a much greater rate from those individuals. Nationally, it's about 16% of our organs come from that mechanism of injury. In my state of Pennsylvania, we are almost close to 25%. Now, I can tell you that being involved in the transplant team, transplanting hearts and lungs, it always seems to me to be a little bit higher than that, but statistically, that's where we fall. Now, switching gears a little bit, I'm going to be talking about naloxone and Narcan. And before we do, how do we even know that it works by putting naloxone into the hands of lay people? This is older information. Again, this comes from the CDC, from the Morbidity and Mortality Weekly Report, that we already know that naloxone is effective to decrease overdose deaths. It is safe, it is cost effective, and it is recommended to be in the hands of any layperson who may witness a drug overdose, any individual who is leaving incarceration, leaving a treatment program, or is currently prescribed opioids. So you can see that this encompasses a very large group of individuals. A lot of people should have naloxone on hand. Now, other things that will also decrease mortality, having either a naloxone access law or having Good Samaritan laws specific to drug overdose is known to decrease overdose deaths by about 15%. This effect is even more prominently seen in the African American population, whereby it decreases deaths by about 25%. So this has led myself and others in the ASA's COTEP committee, the Committee on Trauma and Emergency Preparedness, to spearhead the ReviveMe.com campaign. So this is the ASA's National Overdose Rescue Campaign. This is myself, Armand Dahl, Joseph Sokol, and Albert Varon. We unveiled or introduced this to the ASA in 2020 during our virtual meeting. And this is obviously our immediate past Surgeon General, Dr. Jerome Adams. He was kind enough, he recorded an introduction, kind of an advertisement for the program. His family has also been affected. His brother is incarcerated related to substance use disorder. He is also very much an advocate. So here it is, our campaign. It's revive, all caps, lowercase, me.com. You can log on to it as you're sitting there. And it is an educational program for our members of the ASA, but it's also available to the public. So this is a microsite inside of the ASA's website. It is available through any search engine. Just have to be careful to put the revive all caps. If it's lowercase, it'll take you to a Christian revival site. Not that there's anything wrong with that, but so revive has to be all caps. Anyway, as you open up the website, there's me. It's a TED style talk where I'm trying to convince people based on my lived experience, what I've been through. Please have naloxone in your home and have some basic skills. Also on the website, there is a slide deck. If you want to go out and teach in your community, in your synagogue, you can download a set of slides and you can talk. And we'll go through actually some of these slides here, or what that content is. There are links to Next Distro, which is a free mail to home service where people can click, any community member can click on it and they can have naloxone sent to their home for free. It's, unidentifiable essentially. There's also the American Heart Association and the ASA's joint statement on opioid overdose response. So there's a lot of content there. Anybody can go to it. I highly encourage you to send a patient or a community member to the website. Things that we talk about on that website or that are in that slide deck is that the majority of overdoses happen in a home, either in the victim's home or in someone else's home. The average time that it takes to get EMS to your home is 7.5 minutes. If you're in a busy inner city area or they can't quite find you on the grid, it can be quite a bit longer. If you're rural, it can take up to 14 minutes. That is a long time if you're standing there and someone is not breathing or they progress to they don't have a pulse. It takes 2 to 3 minutes to get a response from intranasal naloxone. And I always make the point with individuals that after 5 minutes of no oxygen to the brain, that you're running the risk of significant brain injury or brain death. This is common language that I'm speaking to you in. This is the type of information that people need to hear and that they want to hear. I talk to them about how an overdose death actually occurs. And I go through in specific points. The individual falls unconscious. Then eventually their breathing slows, breathing stops, the brain's not getting oxygen any longer, the heart slows and then stops. This is how people die. And when you explain this to a layperson, they get it. And I tell them that if you interrupt this process on the far left-hand side, when they're just falling unconscious and their breathing is starting to slow, that's how you can really save a life and get them through this without injury. The little picture on the left, I like to tell them that exactly how naloxone works. And again, they get it if you give them a very basic description of the receptors. These are little landing zones. We don't go through a lot of detail, but if I tell them these are little receptors in the brain and that's where the opioid is sitting, that you giving naloxone displaces or pushes off the opioid from that receptor, and that allows the individual to wake up, to start breathing again. Sometimes people say, well, I gave naloxone and it didn't work. Well, you may not have displaced enough of the opioid from the receptor, and that's why potentially it didn't work. We also talk about the fact that naloxone only acts for about 30 to 60 minutes, so you need to stay with them, get them to the ambulance or whatever their next step is going to be, but realize that that opioid, if it's not processed by the body, not metabolized, it can come back onto those receptors, and that's how the individual falls unconscious again. I get this question all the time when I go out and teach in the community. Well, how do I know if somebody's overdosing? And clearly, if the individual is unconscious, you can't wake them up, they have a history of substance use disorder, or there's paraphernalia on the scene, then you're looking for things like pinpoint pupils. I show them pictures of what it looks like. Their breathing is either slow or it is stopped. They're gurgling, their lips are blue, their fingernails are blue. It's highly likely this person is overdosing. So again, this is material that's all in the slide deck on the website. If you find somebody who is unresponsive, you call 911, you administer naloxone. If the individual is not, is breathing, then they have a pulse. So you stay with them, you turn them into the recovery position. If they're not breathing, you give 2 rescue breaths and then 1 breath every 5 seconds. This is basic life support. If they are not breathing, do not have a pulse, then you're going to start chest compressions. And we talk about the bare basics, where to put your hands and how to do chest compressions. If you call 911 and you tell the dispatcher that you have somebody who is not breathing, they are going to give you instructions over the phone. They will tell a lay person where to put their hands and how to do hands only chest compressions. So I tell people, this is not the time to be learning how to do it for the first time. So if you're in a high risk situation, high risk home environment, is to please learn. Where can you pick up naloxone? You can walk into any pharmacy in the United States, and there is either a standing order, which is a standing prescription that is written by the physician general of that state. That is a prescription that is for everyone in that state. In the states that do not have a standing order, there are naloxone access laws that allow the pharmacist to distribute to anyone who asks for it. So it's available if you should need it. Good Samaritan laws. There are only 3 states in the United States that do not have Good Samaritan laws specific to drug overdose. That's Wyoming, Kansas, and Texas. This is my last look at the information. However, they do have Good Samaritan laws. So no one should really be fearful of litigation or being held responsible if you intervene with naloxone or basic life support skills. There are laws in place to protect you. Having said that, I also get a lot of questions about, do I need to be CPR certified in order to save a life? And the answer is no. I would encourage you to. However, whatever skill level that you have, if you choose to intervene, you will be legally protected under Good Samaritan laws. We talk about knowing the signs of acute opioid withdrawal because, of course, you're giving the reversal agent. So these are typical symptoms of drug withdrawal, which would be, for people in addiction medicine, these are signs on the COWS scale, the opioid, withdrawal symptoms. So having a runny nose, goose flesh, vomiting, diarrhea. These people feel very, very irritable and agitated at times, especially if you've overshot with the naloxone dose. So I caution people that as you're reviving someone is to hopefully they start breathing again, they are awakened, they are interactive, but to give them space. They're usually down on the ground. You're hovering over them, is to back away from them, talk to them, tell them what happened. They're terrified. They have no idea what happened to them. But again, to just stay with them, and hopefully that individual um, gets into the ambulance and goes on to whatever it is their next step in their recovery. We talk about having a household plan, discussing the risk. If there's anyone else in the family who's willing to interact in an overdose situation, I always talk about having naloxone in a central location such that it's secure, nobody touches it, whatever other equipment you want to help rescue that individual, whether it's gloves, a face mask, or a face shield, to have that available and in a protected site. To give some type of instruction, have who's in the family who's willing to interact with the individual, who's calling 911 to actually go through a dry run and to talk about it as a family. If you're the only person in the home with that individual, that I recommend always having your cell phone on you, or my iPhone, which is currently ringing. It's probably spam. But the point there is to put your cell phone on speaker mode. It allows the individual to use their hand and talk, or excuse me, respond to the victim and talk to the dispatcher at the same time. They're often giving you instructions over the phone. Again, this is for a layperson. It also gives you a timestamp, so you know what time you gave them naloxone the first dose, and then you can time it on your cell phone. I always recommend, if you have a high risk home, to have some means of opening a locked door. Most of us in our homes, we have either the push button knobs or you have the turn knob for the doorknob. This would be bedroom and bathroom, because most people aren't using sitting in the family room out in the open. They're usually using in privacy. So you can get either, you take the blunt end of these little shish kebab skewers, you can take that and you can pop open the central pin, or you can buy this little device here at any hardware store. And it's this hooked edge here that you use to turn the doorknob on the ones that you have the little turn in the middle of the doorknob. These devices can be placed above the door frame. Nobody even needs to know they're there. And by the way, these are very helpful if you have a small child who locks themselves into the bathroom, or bedroom. So it's a good device to actually have on hand, whether or not you have this situation. Again, the reviveme.com website you see there, this is an infographic that any member of the community can download and print out, and it just goes through the basics. We emphasize getting training either through the American Heart Association or the American Red Cross. Methods of delivery for naloxone. The lion's share of the market is the product that you see on the left-hand side, which is the pink and white box that you see here. This is Narcan nasal spray by Emergent Biosolutions. It used to be called Adapt Pharma. But that box has 2 doses of Narcan. Very easy to use. You just pull off the foil. You put your fingers on either side of the nozzle, your thumb on the little plunger, and it's just one simple push. It's easy. It's a nasal spray. If you go to the pharmacy and purchase this because you don't want it on your insurance, it's about $145 for a box of 2 doses. If you have commercial insurance, it runs anywhere from about $35 to $40. If the individual's on Medicaid, it is no copay. A lot of state insurances now, 0 copay. I can tell you that if you go to your county health department, your public health department, they will frequently, you walk in, you ask for it, they'll hand it to you for free. I already mentioned the Next Distro website, free. So if there's a need, there's really no reason why you couldn't have it in your home or anyone to have it in their home. There are ways to get it for nothing, no cost. The product that you see in the middle is generic naloxone. It is a Bristojet. So you can see it's like any other Bristojet that we use. You have to take the pieces, you screw them together. It's a little bit more time consuming. It's a little cumbersome if you're a lay person um, and you're nervous, your hands are shaking. It's a little bit harder to put together. But you'll see me using it in the video that I'll display shortly. But it is cheap. Um, that dose also is only 2 milligrams. The other device I'm just going to mention here, it's no longer commercially available. It's not being sold, is Evzio auto injector. It's kind of a cool device. I have one here. It's a very expensive device, but for lay people,
are ready to use. Pull off red safety guard.
so it's nice in the sense that if you're a lay person, it talks to you, it tells you what to do. You pull the red tab off, you just push it right up against a large muscle group, the outer arm, the thigh. It's an IM injection, it goes right through clothing. The reason I'm mentioning this is some people have been discharged from treatment facilities or incarceration and they still have these devices. So if you see this, that's what it is. IM injection, it's also 2 milligrams. So I took this picture when I was out in a public space, and you can see that there's lots of equipment on the wall. We are prepared to respond to a fire, a mass casualty, a VT or VF event, but there's no naloxone on the wall. So I am advocating in the United States to have naloxone next to every AED in the country. There's no reason not to have it. The big sticking point is that it is not over the counter as of yet, but I'm working on that. Clinical initiatives, I'll just briefly mention there are many, many screening devices that you can use to screen for substance use preoperatively. There's SBART, and you can have them fill it out either on iPad or on a piece of paper. I like to have what I call the use conversation. So I do this with every single patient, bringing them into the room, putting the non-invasive monitors on, and I say to them, tell me, what do you use to help you relax? And I list the medications, Xanax, Ativan, Valium. Do you drink alcohol? What do you drink? How much? Have you struggled with alcohol? Finally, I talk to them about things like a lot of my patients, I try to normalize it. A lot of my patients take pain medication, oxycodone, Percocet, oxycodone. Do you use any of those? Then finally, I get into the recreational substance. Do you smoke weed? Do you use CBD gummies? And again, it's maybe legal in some parts of the country, but not everywhere. And I asked them about cocaine and heroin. It never surprises me when people actually reveal it's their use. It's a very uncomfortable time for them. They're nervous. It's pre-op. We're just about ready to go to sleep. I do tell them, though, that I do not discriminate. I ask every single patient these questions. I let them know that I am responsible for this to be a safe and comfortable procedure. If you know what works, please tell me, and then I don't have to figure it out. Also, I can be a link to services. So if someone indicates that they're struggling or they're thinking about cutting back what they're doing, that I can hook them up with a CRS, a certified recovery specialist, that will visit with them post-operatively. So I would encourage you to look into what's available at Stanford, at your institution. How can you link someone to services? And finally, I'm going to move on to a video, which I will just set up the scenario for you. I had just finished my grocery shopping. I had a whole car full of frozen food, getting onto the highway. And at the base of the on-ramp, I saw there were a number of police cars that were stopped. There were civilian cars that had also stopped. There was a truck. The door was open. There was a young man that was on the ground, and the officer was performing CPR. So I felt compelled to stop because There was no medical squad on the scene. It was clearly a medical emergency, and the whole situation didn't seem right. So I'm just going to play this for you. This is a body cam video of the officer and what he's seeing. And then later on, embarrassingly so, you'll see me come into the picture. It's amazing the things that you say and you do, and you're like, oh, did I really do that? All right. So, I mean, clearly, this is not Dr. Bonnie Milas standing at the foot of the bed instructing people on what to do. This was a crime scene. This was a police scene, and I wasn't in control of the circumstances there. But the length of this tape was over 9.5 minutes. So, first thing to recognize is how long it took for EMS to get there. So, if it weren't for the actions of the community members, and there was a woman who gave mouth to mouth resuscitation to a complete stranger, she was willing to intervene. So, people in the public are willing to step up. Um, the reluctance of the police, I don't think the police officer who was doing the CPR knew that the girlfriend had said that this individual had just used. So that's why he kept asking. He was very reluctant to give the naloxone. And then the fact that I kept telling him, hey, I can do CPR, but he was insistent on doing it for the full like 10 minutes. But anyway, he did an exceptional job. I'm just going to finish up with, you have to think as a community member, what are the circumstances during which you would intervene? Is it the scenery? Is it the situation that may influence you? Is it the look of the person? Would you be potentially biased about whether or not to intervene? Or whether there are compelling circumstances, like seeing that there's a child on the scene that needs to be cared for, whether that would influence you to intervene or not. Or maybe it is you would only do this in your home with your family members and with your friends. So it gives us something to think about. I would like you to think about how you would envision interacting in a circumstance. There are different levels of engagement. I do think that the ASA should take this on as a national charge, that this would be an important way for anesthesiologists or anesthesia professionals to step up and to be visual in a very prominent way. I think this will become especially important if naloxone becomes an over-the-counter medication. But these stars here, different levels of engagement, with the first one being to carry naloxone, to have it available in your home, and to encourage others to do the same, to educate in your community. And then, if nothing else, if you would at least please send people to the reviveme.com website. I think that's probably the bare minimum of involvement. It doesn't take you any time or any effort. So I'm going to close it down now. And see, we might have a minute or two left for a question. But thank you, Stanford, for having me.